Good afternoon, and thank you for joining us for today's Nevada Immunization Learning Exchange webinar. This is Brianne Van Dyne, the Education Manager for Immunize Nevada, and I am today's moderator. First, before we get started, I'd like to review a few housekeeping items. If we should become disconnected for any reason, please log in again and we will continue. Second, please locate the Q&A box at the bottom of your screen. If you have any questions, type them there and we will address those at the end of today's presentation. Additionally, if you are interested in claiming nursing or community health worker continuing education credits for today's webinar, please make sure you complete the survey, which will pop up on your screen when the webinar is ended or in a post-webinar follow-up email. All CE nursing and CHW certificates will be emailed out within the next week, and we'll be reviewing the steps necessary for claiming a CPE credit for pharmacists in attendance today on the next couple of slides. Finally, please note this webinar is being recorded. The archived presentation and slides will be available on immunizenevada.org/webinars within 1 week. So Pharmacy Times Continuing Education is accredited by the Accreditation Council for Pharmacy Education, or ACPE, as a provider of continuing pharmacy education credits. And this activity has been approved for 1 contact hour under the ACPE Universal Activity Number you see on the screen. The activity is available for CE credit only for live participants on today, October 27th, 2020. This is just a few instructions for how you obtain that ACPE credit, and we will be including this link in a post-webinar follow-up email to pharmacists in attendance today. Before we officially begin, I'd like to provide a little disclaimer. Immunize Nevada's NILE webinars are made possible by the generosity of speakers who donate their time and expertise to benefit the coalition. The expectation and goal is for community partners to gain knowledge on immunization and infectious disease-related topics through a non-branded, unbiased presentation. I'd like to now turn it over to today's featured presenter, Rupal Mansukhani, pharmacist and clinical associate professor at Ernest Mario School of Pharmacy at Rutgers University. Rupal completed her Doctor of Pharmacy degree in 2004 at the Philadelphia College of Pharmacy. Upon graduation, she completed a PGY-1 community practice residency at the University of Illinois in Chicago. Until 2012, she worked as a community practice at Pathmark Pharmacy, where she taught students about clinical outpatient services. She currently practices at Morristown Medical Center and transitions of care. Her areas of interest include respiratory conditions such as chronic obstructive pulmonary disease, asthma, and pneumonia, with a special interest in advancing immunization rates. Welcome, Rupal.
Thank you. So today we're going to be talking a little bit about influenza vaccinations and some opportunities for pharmacists, basically as patient advocates, educators, and administrators. So I'll discuss the educational objectives on the next slide. So at the completion of the activity, participants should be able to examine the etiology and transmission of influenza virus, identify patient populations at risk for influenza-related complications, and the critical nature of the ACIP recommendations, analyze the safety and efficacy of the types of influenza vaccines available in the 2019-2020 influenza season, and then explore the interventions that pharmacists can implement to dispel patient misconceptions regarding some of the vaccines that we're going to talk about. So I did want to say, and I missed discussing the last slide, that this activity was supported by an educational grant from Sanofi Pasteur, and this activity is sponsored jointly with Rutgers Ernest Mario School of Pharmacy, and I have nothing to disclose. So before we begin, we'll go through our pre-test questions. So our first question is, and I'm just going to let the question launch. So before participating in this activity, how confident are you in making influenza vaccination recommendations in high-risk populations? So do you feel that you are not at all comfortable or confident, somewhat confident, moderately confident, or extremely confident? So please answer now. Our second question is, MG is a 49-year-old woman who comes to the pharmacy for her annual influenza shot. She's concerned about getting influenza. She smokes about 1 pack per day, drinks about 2 beers 3 times a week. Her family history includes a mother who has hypertension. Her blood pressure is 118/68. Her BMI is 42, and her total cholesterol is 158. So the question here is, why is MG considered high risk for developing influenza complications? So is it because she is 49 years of age, a mother who has hypertension, blood pressure is 118/68, or BMI is 42? And so the question is really addressing, why is she at high risk? So our third question is, RK is a 68-year-old man who comes to the pharmacy to pick up a prescription. He wants to get an annual influenza shot. Which vaccine would you recommend to reduce his cardiorespiratory disease? So is it that the patient has the patient would benefit from a quadrivalent inactivated influenza vaccine? Would the patient benefit from quadrivalent recombinant influenza vaccine? Would the patient benefit from adjuvanted inactivated influenza vaccine? Or finally, would the patient benefit from high-dose inactivated influenza vaccine? And finally, or we have 2 more questions, but the fourth question is, pharmacists are integral to reducing misconceptions about vaccinations. Which strategy is most appropriate to convince a patient who is concerned about getting influenza from influenza vaccines? Is it to discuss the adverse effects with patients, stress the number of deaths that occur each year from vaccination, use facts such as how many patients you've vaccinated already, or finally refer the patient to a pro-vaccine website? And then our last question is a multiple choice question. Which of the following is true regarding influenza virus? Is it people with flu are most contagious on the first day of symptoms? Healthy adults may be able to infect others beginning 3 to 4 days before symptoms develop. Young children and people with weakened immune systems might be able to infect others with flu viruses for a longer time compared to those that are healthy, or symptoms typically present gradually over the course of a few days.
And we'll give attendees just a minute or so to answer those pre-test questions. Just as a reminder, the pre and post-test questions are required to be completed for the ACPE credit. However, we encourage all participants to participate in the pre and post-test live. And we'll give you just a couple more seconds to complete that. Okay, it looks like responses are kind of tapering off a bit. We'll go ahead and end polling now.
Okay, great. So let's talk a little bit about influenza. So influenza is a viral respiratory illness that spreads through droplets. Let me just get to that slide. Okay. And usually what we see in patients can range from a mild to severe illness. And if it gets to the severe part of it, we can even see patients that die. And the problem with influenza is that it comes on pretty suddenly, and it's most contagious in the first 3 to 4 days where the illness begins. And patients can become contagious 1 day before the symptoms actually develop. So patients start spreading this to other patients before they even know they're sick. And it can be up to 5 to 7 days after becoming sick. And the patients that surprise me the most are the ones that are young children or patients that have weakened immune systems. And that's because those patients tend to be contagious for even a longer period than that 5 to 7 days that we generally see. So the symptoms we usually see patients present with is fever, cough, sore throat, runny nose, body aches, fever, fatigue, headache. And that's what we usually just kind of use to differentiate between patients that are actually have a common cold versus someone who has a flu. So it's really that fever, that fatigue, that body aches. The truth is, before I go into this presentation, what I want to tell you is that if we had every patient that got the flu to just stay at home and kind of recover with those symptoms at home, we probably wouldn't vaccinate against it. But it's really those patients that have the complications that are the ones that we're targeting. So let's talk a little bit about the nomenclature. So the types of influenzas, A or B, and within A, you can classify it into A, H1N1, or A, H3N2. And if you go into D, you can see that it can go into the Victoria or the Yamagata lineages. And so on the next slide, I have a breakdown of the 2021 vaccine. And this year was the first year that the World Health Organization actually changed the strains a little bit based on what type of vaccine you were getting. So you can see that if the patient is getting a vaccine that is egg-based, it will have 2 type A strains and 2 type B strains, and those are listed for you. And if you have the cell cultured or the recombinant vaccine, you can see that you also have 2 type A, but the type A actually changes to a Hawaii strain. And then for the B strains, the Washington and the B Phuket remain the same. So there is a different A strain in the recombinant vaccine compared to the egg-based. And you could see that, you know, our strains from last year compared to this year, and you will see time and time again that some of the strains kind of carry over. But for last year's strain compared to this year's strains, we have seen that we have some major changes where we have 2 new A-type strains and a new type B strain. So something to kind of think about as we're thinking about vaccine efficacy. So our Healthy People 2020 objectives were here. And we know they're still evaluating to figure out, you know, did we meet the objectives? But the 2030 goals were just posted, and all these goals, and they're generally general health goals, but all of them include some kind of vaccination goal of we're trying to vaccinate patients at a higher level. And so typically, we're depending on what region or what group the patients fall in, we're trying to vaccinate at least 70 to 90% of the population. So what's going on now? Right now, you can see on my next slide that I have a little syringe that shows coronavirus, right? And of course, coronavirus is a big issue, and it's going to be a big concern while we go into flu season, because trying to identify which patients have flu and which ones have coronavirus is going to be difficult. But for today's presentation, we're going to kind of focus on flu. So my next slide talks a little bit about the visits of influenza-like illness. So these are the patients that basically have some kind of symptom. They have flu-like illness, and they're going into an outpatient center, either a doctor's office or an urgent care center or something like that, and saying that they have flu. And you can see from this red line that you see on this graph, this is from this past season that we had, the 2019-2020 season. And the 2020-21 season is just beginning. So we're not seeing so much data just yet. But you can see that we had a pretty severe season this year. And this black line that is all the way to the left of the presentation is our H1N1 pandemic. So if you look at H1N1 pandemic and compare that to what we saw this past year, we got pretty high in the number of cases that we saw, and we actually had 3 peaks, which you can see in most years, that's not normal. The next slide talks a little bit about the hospitalizations that we see in patients based on age. And so you can see that the 2017-2018 season was pretty severe with hospitalizations, and followed by that was our most recent flu season that we had, the 2019-2020 season. And with every flu season, there's pediatric deaths. So our next slide kind of covers the different pediatric deaths. For the 2019-2020 season, we saw about 174 deaths. And I think that number is a little bit higher. It's in the 180s now. But something that, you know, we definitely want to kind of focus on because we're seeing more and more pediatric deaths. And when we looked at the 2018-2019 season, which is a pretty severe season, what we saw was that it was a moderate season that lasted long. And in patients, what we found was that there were about 116 pediatric deaths that occurred, and the mean age for these pediatric deaths was about 6 years of age. And so of the 116, there were 104 of those patients where we actually had a known medical history, where we were able to actually evaluate. And the CDC has changed the way we report pediatric deaths, so we can really look at, you know, what patients are being affected and how we can prevent these patients. And what they found was nearly half the deaths of this, the patients that died that season occurred in previously healthy patients. They didn't have comorbidities. But the problem was that most of them that did die had not been vaccinated against influenza. And something very alarming. So when we look at the burden of illness, you can see that on average, in this next slide, we see this triangle, and you see that you have about 9 million to 45 million illnesses each year. And this is 2017, 2018. And of those, we have 140 to 810 hospitalizations. And then of those, we have anywhere from 12,000 to 61,000 deaths. And you may ask me, you may say, Ripple, you know, why is there such a huge death range, right, from 12,000 to 61,000? And the reason the CDC does this is they have to kind of have this predictive model, because if a patient comes into the hospital and they had flu, and their flu complicated their COPD, and so now they come in with a COPD exacerbation. In the hospital, they're listed as a COPD exacerbation, and if they die during their admission, they may be listed as a death related to COPD, but in reality, that patient's exacerbation was caused by the influenza. And so that's why the CDC does this range, and you'll see this on most of the data that they show. So every year when we're looking at flu, and a lot of these slides, and I saw a comment show up like, are we going to have these slides available? And so if you look at the bottom of my slides, you'll see that on the next slide, you'll see that there's a website, cdc.gov/flu. And in there, they have all this surveillance data that I'm actually sharing with you. And the nice part about it is that it's real time. So there is a delay. They say it's a 2 to 3 week lag period from the time that flu season hits to the time that it's reported online. But overall, it's pretty good to kind of let you know your geographic location and what kind of strains are circulating and how much flu you're actually seeing within your geographic location. And so this slide kind of, and I just kind of picked 2 random weeks to kind of show you, but you can see that for this slide that I picked in May, week 11 had 93%, so I'm looking like in the middle of the section under week 11. You can see 93% of patients were reporting H1N1 and 7% were reporting H3N2. By the time we got to week 14, 96% of them were reporting H1N1 and only 3.4% were reporting H3N2. So it'll kind of give you an idea of what strains are circulating. And what we typically see is that years where we see an H3N2 season, we have a little bit less vaccine efficacy compared to a normal H1N1 season. And that goes a little bit back to the virus and the way that it mutates. But, you know, you can see from last season where we saw, you know, H1N1 90% of the time, that we had a pretty severe season. So it's not just black and white where you can just always assume that, but this is generally what we see. So the next slide shows you another flu view picture to kind of just tell you, you know, what kind of strains we're seeing. And so you can see the A strains are in the orange color, the B strains are in the green color, and it gives you a week by week surveillance to kind of give you an idea of what kind of circulating strains you have. Because once you identify what kind of circulating strains you can kind of identify what kind of strains are in your vaccine and see if the strains that are actually circulating are the strains that you're actually protecting patients against. And this is what happened with the pandemic of 2009, 2010 with the H1N1, where the CDC started seeing a number of H1N1 being reported, but it wasn't in our vaccine. And that's when they created that vaccine, and we did that second vaccination that season. And so let's talk a little bit about vaccine efficacy. So 2019, 2020, the vaccine efficacy was overall, and these numbers have been updated a little bit, but the overall vaccine efficacy was about 39%. In the interim report, they actually had it a little bit higher. They had it at 45%. But either way, 45% or 39%, it's not a great number, right? And it's like, okay, so 40% effective, is it even worth me getting, right? And you could see that the vaccine efficacy against the A strains are a little bit less compared to B strains. And so the next slide kind of shows you the last, from 2005 to 2019 and the vaccine efficacy. And, you know, year after year, I'll see this on the news where they'll say, oh, you know, the CDC missed again and the vaccine efficacy is low. But you can see that we're pretty consistent. I mean, some years we've been really low, like 2014, 2015, and 2018, 2019. But overall, we're like in the 40s, right? That's our average. And so we started capturing this data back in 2004. And we really kind of wanted to look at vaccine efficacy because that kind of gives us an idea of what we should do. So I have patients ask me this all the time where they say the vaccine efficacy is not great, so why should we vaccinate? And that's a hard question for us as pharmacists to answer. But luckily for us, the CDC came up with some marketing campaigns, and they kind of started looking at, okay, although patients may still get influenza, are they getting a milder form of the illness? And are they having less hospitalizations? And are they having less deaths? So I told you earlier in my slides that 2017-2018 season was a pretty severe season. And so the CDC has some data for that season. So the benefits of flu vaccination for the 2017-2018 season is that 6.2 million flu illnesses were prevented. They prevented 91,000 hospitalizations and about 5,700 deaths. And so based on the patients that actually got flu vaccine, we do have some benefit. So who do we want to target? Who are our high-risk populations? And so those patients are on this slide, and this is kind of who you're trying to target. So first, it's anybody that's hospitalized, right? And this is important for flu vaccine. Like, you know, obviously everyone 6 months and older should get vaccinated, but these are the patients that are high risk that typically get hospitalized and the ones that die. And so we want to really focus on these patients. And then we also want to make sure that these patients are the ones that we start early treatment on if they do have flu-like symptoms. So if a patient is hospitalized, you don't wait till a flu test comes back positive before you start treatment. You always start treatment and then you can always de-escalate. You have a patient who has diabetes that comes in and they have flu-like symptoms, you treat them on treatment, and then you assess whether or not, you know, they actually have the flu or not, because we can always de-escalate patients off of antivirals. So here's your high-risk groups. Patients that are hospitalized, patients that are less than 59 months, patients over 50, and this is like huge. And most of the time when we see vaccine-related stuff, we think 65 and older. But flu and coronavirus actually both have a higher risk in patients 50 and older. And then anyone who has a chronic condition, if the patient is immunocompromised, we're really concerned. If the patient is pregnant or 2 weeks postpartum, if they're less than 19 and they're on some long-term aspirin therapy, anyone in close quarters where they're living in like dormitories or long-term care facilities, and then Alaskan Natives and American Indians, as well as patients that are obese. And that really surprises me too, the obese patients. But most patients, when we talk about influenza-related complications, they usually recover within a few days to less than 2 weeks. So like I said, the patients, if everybody could be in this BLIT 1 where they recover in a few days to less than 2 weeks, we would not vaccinate patients. We would not treat patients. But it's these complications and these deaths that we worry about. So the pneumonia, the myocarditis, the encephalitis, multi-organ failure, and worsening of chronic conditions. So let's talk a little bit about what's new for 2020-21. And so most influenza vaccines for this year are available in quadrivalent. And so there's no more trivalent on the market, which is great, right? Because for years, we've been kind of like, do we give trivalent high dose or do we give quadrivalent standard dose, right? It's always been kind of a question for us. So no more of that. And then we have Baloxavir, which is on the market. So we're not going to talk too much about Baloxavir, but that's a new antiviral on the market. We have an adjuvanted vaccine that is available both in trivalent and quadrivalent. And then we're going to talk a little bit about contraindications to the live vaccine as well as an egg allergy update. So we recommend that everyone 6 months and older who does not have a contraindication be vaccinated. And the next slide just kind of gives you a quick recap of the types of vaccines that are available. So we have inactivated influenza in standard dose, in adjuvanted and high dose. We have the recombinant vaccine, the IIV4, and then we have the live attenuated vaccine. So dosing recommendations are listed here for you. And I'm actually not familiar with Nevada law, and I probably should have looked this up before I presented to you, but I'm not sure if you guys can do pediatric dosing, but what we really recommend is if you do have pediatric patients that are less than 35 months, that you look at the manufacturer package insert. And the truth is, I actually recommend it for everybody, regardless of your state, that you know, anytime you get a vaccine in your pharmacy, you should look at the package insert to see what the dosing recommendations are. But there are some studies that show that, you know, if we give a 0.5 ml dose to pediatric patients, which we typically historically have always given half the dose, 0.25, we induce a higher antibody response compared to that smaller dose. And that's without causing higher rates of any kind of systemic or injection site reactions. And so if we could protect these babies that are at high risk more, then why not give them that 0.5 ml dose? So some of the manufacturers have gone through FDA to get that higher dose approved in the pediatric less than 35 months of age, but some have not. So you really have to, if you're doing the pediatric patients, you definitely have to look at the dose. And what we normally do is we give 2 doses the first time the child is getting vaccinated, 4 weeks apart. After that, we can go to 1 dose. And then once they get to adulthood, after 9 years or older, we would basically give them 1 dose, even if they haven't previously received 2 doses. So let's talk a little bit about our patients that are 65 and older and vaccines that are licensed for them. And so we have, and this is a typo, I apologize, but it should say quadrivalent high dose vaccine because that is a change for this year. And the high dose vaccine was first FDA approved in 2009. And it basically has 4 times more antigen compared to the standard dose. And the thought is that, you know, what we find in our patients 65 and older is that when we give them a vaccine, it doesn't give them that immune response that a patient less than 65 may get. And so, well, if we give them more antigen, we may get a better antibody response, and as a result, may have better protection. And then we have the adjuvanted vaccine on the market, and I'm going to talk about both of them in a little bit more detail. So let's talk first about the history of the high-dose influenza vaccine. So in 2009, the FDA licensed the vaccine, and what they found was that it was safe and effective, right? So FDA is only looking at safety and efficacy in patients. So they found that it was safe and effective in patients, but the ACIP, the Advisory Committee on Immunization Practices, really wanted to get an idea of, you know, why do we want to vaccinate these patients with something that has 4 times more antigen? We want to prevent hospitalizations and we want to prevent deaths. So they didn't want just the data for safety and efficacy, but they wanted to know how many hospitalizations it prevented and how many deaths it prevented. So in 2014, they came out with a study and they found that the relative vaccine efficacy was better in the high dose compared to the standard dose. And what they basically found was that for every every 1,000 patients that you treated. So if I put if I put 1,000 patients on side A of the room and vaccinated them with high dose, and I put 1,000 patients in side B of the room and vaccinated them with standard dose, we would typically have 4 to 5 less cases in the A group, the high dose group. And so that was good data. But again, ACIP wanted to know, well, of those 4 or 5, how many of them would have died and how many of those would have been hospitalized? So in 2015, they came out with data with all-cause hospitalizations and pneumonia. They also published some data with cardiorespiratory events showing that the high dose was more effective. And then in 2017, they found that they looked at 2 influenza seasons and found that the rate of death was decreased with high dose compared to standard dose. And then this was the first year that there was actually a randomized controlled study that was in nursing homes patients who we know are high risk, and that high dose was found to be beneficial. And then in 2018, they looked at VA patients and cardiovascular patients, and they found that it was beneficial to be there. So we've had like a long history of high dose vaccine showing time and time again that it is beneficial. So this was all great. As we're getting all this data in 2015, we have the Adjuvanted come to market. And the Adjuvanted was out in other countries for many, many years, but in the US, it's pretty recent, the last 5 years. And what we found was that the relative vaccine efficacy in this Adjuvanted product was good. And what they found was that a large cohort study that looked at 2006 to 2009 influenza season found that giving somebody adjuvanted vaccine was preventing more cases of flu compared to patients that were receiving the standard dose. And so although the adjuvanted vaccine was showing that it was reducing hospitalizations and reducing deaths, we just didn't know where it fit and how it kind of looked compared to patients with high dose. And typically, you know, we don't see patients or we don't see manufacturers do head-to-head studies to kind of look at which one's better, high dose or adjuvanted. But lucky for us, there is a study. So in 2020, the Vaccines Journal actually published a study, and that's on the next slide. So, and they looked at the comparison of the effectiveness of high dose versus adjuvanted influenza vaccine. I'm just waiting for the next slide. Perfect. So these patients were patients that were 65 and older, and it was a retrospective cohort study. And they basically had patients either get high dose or adjuvanted. And they looked at the 2016 to 2018 season. So I created this little chart on the next slide that shows you the results of this study. And you can see that in 2016, the 2017 season, we have our respiratory disease followed by our cardiorespiratory disease. And you could see that there's a relative vaccine efficacy about 14 to 15%. And then in the following year, there was a 5 to 11%. The overall, what we found was that the data was promising, showing that high dose did prevent more cardiorespiratory conditions compared to patients that were on adjuvanted. So it did show a benefit in showing benefit for high dose vaccine. Now, this is just one study over 2 seasons, and it wasn't a randomized controlled trial. So I do realize that, and I think that we need to see more of that data before we can say that high dose is superior to it. But this data did show that the high dose vaccine was better than the adjuvanted vaccine. So let's shift gears a little bit and talk a little bit about the live influenza vaccine. So the live influenza vaccine has kind of been all over the place. And so this is historically thought of our nasal vaccine, the flu mist, and it's indicated for patients that are healthy between 2 and 49 years of age. And we've kind of gone back and forth about this because we had some data in 2017, 2016 that kind of showed that, and so actually, let me go back. So what we did was there was a study done like in the early 2000s that showed that in certain patients, the live attenuated vaccine was more effective. And so what we did was we started recommending it preferentially, I think back in 2013, 2014 timeframe. And what we found was that season when we preferentially recommended it, that patients that got the flu vaccine through the live attenuated vaccine had actually an increased risk of having flu compared to patients who didn't get vaccinated. So of course that did not look good at all because it was showing that patients who got live attenuated vaccine had a higher risk of flu compared to patients who got placebo. And so the CDC and the ACIP basically took it off the market for a few years. And it came back the last few years, but the American Academy of Pediatrics didn't recommend it. And then last year, they basically said, okay, according to the CDC and AAP, we can recommend it and see how it goes. And so we're still there where we can continue to recommend it, but it's not preferentially recommended. And then our recombinant influenza vaccine comes in the quadrivalent. And that's something that we want to make sure that we kind of look at. Oh, I forgot to add this slide. I apologize. So I forgot I added this slide. So can you go back to the next slide? Thank you. So there are some new updates that I want you to be aware of. And so this is something that was added for this 2020-21 season where we added CSF leaks, any kind of nose or ear, any kind of leaks or hearing implants to the contraindications of live attenuated vaccine. And this is primarily used for healthy patients, so we shouldn't have even seen these patients getting it at all, but they found in studies that it does worsen conditions for these patients. And so now it is added to the contraindication section. And then they also added this, and this is interesting, a contraindication to the vaccine if the patient got any kind of antiviral medications. And so if you got oseltamivir or zanamivir within the last 48 hours, for peramivir in the last 5 days, or baloxavir in the last 17 days. So if in the last 2 weeks somebody was treated with baloxavir, we would definitely avoid giving them the live attenuated vaccine. Okay, so with that, let's talk about recombinant. I'm sorry, I was going forward. So the recombinant vaccine is a quadrivalent vaccine, and it's approved in patients 18 and older. And this is an interesting vaccine because we usually see a slightly shorter shelf life with this vaccine because of the way that it's produced. But the nice part about it is that it does not contain eggs. So the efficacy of this study that I'm going to present is interesting. And this is back from 2017, so you may have seen this data, but I did think that it was worthwhile to include. And so it's a randomized double-blind multi-center trial that was published in the New England Journal of Medicine. And what they did was they looked at patients that either received the recombinant vaccine or the standard dose vaccine, both quadrivalent. And they had about 9,000 participants that were 50 and older. And what we found was that in the RIV rate, in the RIV patients, we saw less influenza. And so the attack rate was about 2.2% in the recombinant group compared to 3.1% in the standard group. And so we saw that there was about 30% lower influenza-like illness in the recombinant group. But again, we had to ask the question, how many of these patients are actually hospitalized and how many of them are dying? And we don't have that data yet. And so we can't assume that the patients are going to definitely benefit from it. But I think that it's because it is something where patients are going to benefit from it because of the way that it's produced. So we're not seeing as much mutation of the virus. And so it may be a little bit more effective. So I want to recap for you the differences amongst the vaccines. So for our inactivated vaccines, we have our high dose, adjuvanted, and regular standard dose. So our standard dose is 6 months and older. Our high dose is 65 and older. Our adjuvanted is 65 and older. And all three of these we can give with chronic conditions. The recombinant vaccine is 18 and older, and you can also give it with chronic conditions. But the one that you have to be careful of to make sure you only include healthy patients is your live attenuated vaccine. And that's indicated from 2 to 49 years of age. So contraindications, the egg allergy always comes up a lot. And in prescribing information, every manufacturer that has any kind of egg particle in it is going to put a severe allergy to eggs. But what we found, and the CDC found, and you can go to the next slide, there was a study that was done by the CDC, and they found the rate of anaphylaxis after all vaccines is about 1.31 per 1 million vaccine doses given. And that's not just flu, that's all vaccines, right? So the chances of somebody with an egg allergy actually having anaphylaxis is like slim to none. And so at this point, the CDC is recommending that if the patient has hives, you can give them any product. And we used to recommend that the patient stay in the pharmacy longer, where they stay for 30 minutes. They got rid of all that. And they said, just, monitor the patient like you would normally monitor a patient. And then they said, if the patient has had any kind of angioedema, respiratory distress, anything other than hives, where they required an EpiPen before or some kind of emergency medical intervention, then you have a couple of different options. You can give the patient an RIV vaccine or a cell cultured vaccine, or you could tell the patient to get a regular flu vaccine, but they have to go to a doctor's office or an inpatient or outpatient medical center. Anywhere we could basically manage that patient's anaphylaxis if they were to experience something. And so they're not saying that you shouldn't get vaccinated. They're saying everyone, regardless of their egg allergy, should be vaccinated. Now, if the patient has anaphylaxis, not because of an egg allergy, but because of just anaphylaxis because of another reason, then it is a contraindication, and I would avoid giving them the flu vaccine. So let's talk a little bit about misconceptions. Why don't patients get vaccines? And, if we were in person, I would probably ask all of you guys, how many of you got the vaccine and why did you get it? And why didn't you get it? Because a lot of these misconceptions that I'm going to talk about are common, right? That you may even find a healthcare professional believing. And so a lot of people think influenza is not serious, so they don't need the vaccine, or that influenza vaccine gives them influenza. I've heard this thousands of times from patients. And I'm like, it's nearly impossible for someone to get the influenza vaccine to give you influenza. It is impossible. And they're like, no, it's possible, I got it. And I'm like, well, you were exposed to the vaccine. You were exposed to the virus before you were protected by the vaccine. And that's probably why you got it, not because of the vaccine. But people are really concerned about severe adverse effects. And people who get the influenza vaccine may feel like it doesn't work because I showed you the data. It's about 30 to 40% effective depending on the year. And then pregnant patients are always worried about harming their child, or unborn child. And so that's always the conception. So as pharmacists, we really need to communicate, and that's key. So we want to make sure, next slide, please. We just want to make sure that we're listening to the patient's concerns and acknowledging them. At the end of the day, it's the patient's choice whether or not they're going to get vaccinated or not. But discuss the benefits of the vaccine, possibly the adverse effects. And then instead of focusing so much on who's dying from it or the number of deaths, kind of start thinking the positive approach. How many lives did we save? And that data that I presented earlier about the CDC is great to kind of talk about that. That, hey, in 2017, 2018, because patients got immunized, we saved 5,700 lives. And then asking questions, is there a cultural or religious or personal belief? Have you had a serious reaction or child with serious reaction? What's your safety concerns? Because all of that is important. So making sure we increase patient education about vaccines is key. And the role of the pharmacist is really to make sure that we make a strong recommendation. And there's a couple of studies that are out there that kind of tell pharmacists that, and healthcare professionals in general, that a lot of times patients don't get vaccinated because they were never told. So I have two children, and I was pregnant both with influenza season. And not a single person, not a pharmacist, not a doctor, not my OB, nobody told me to get the flu vaccine. Now I did because I knew I should, because I teach immunizations, but nobody made that recommendation. And so making sure that we make that strong recommendation. Next slide, please. So we want to make sure that we do proper hygiene and infection prevention. And because of COVID-19, this is something that many states are doing. You know, a lot of people are washing hands, making sure they're wearing masks, doing typical infection prevention. So we may see less cases of flu. And New Jersey is one of the states where, I live in New Jersey, and one of the states where we got hit pretty early and pretty hard. And so in New Jersey, you walk around, everyone's in a mask, no matter where you're going. And so I do predict that we're going to have less flu cases this year if we continue the way that we're going. Making sure that you expand your immunization services with standing orders and recall intervention, and making sure you avoid missed opportunities. So in conclusion, the pharmacist play an important role in high-risk patients. Make sure that you increase adherence to immunization schedules by educating patients, making sure that they're aware of how important it is that they get their annual flu vaccine. So I have some additional resources listed for you. So the CDC webpage is a great resource. We have our, next slide please, the Immunization Action Coalition, as well as the American Pharmacists Association and the NMWR. So I want to make sure I have enough time for questions. So I'm going to go through our post-test questions really quickly. And if you have questions, you can start and putting them in the chat, and then I'll start answering as we go. So first question, after participating in this activity, how confident are you in making influenza vaccine recommendations in high-risk patients? So please answer now. Our second question is, MG is a 49-year-old woman who comes to the pharmacy for her annual flu influenza shot. She's concerned about getting influenza. She smokes about 1 pack per day, drinks about 2 beers 3 times a week. Family history, mother has hypertension. Blood pressure is 118/68. BMI is 42 and total cholesterol is 158. So which of the following makes her high risk? So is it because she's 49 years old? Is it because she has a mother who has hypertension? Is it because her blood pressure is 118/68? Or is it because her BMI is 42? So if you can answer that, and then I'll answer it for you. So in this patient, you know, we talked about that high risk slide. And so patients 50 and older are at high risk. So she's not there, she's almost there. Hypertension is an exclusion. Even if she had it, it's an exclusion from high risk. So isolated hypertension does not put you at flu-related complications. And so the fact that the mother had hypertension doesn't matter. And the fact that her blood pressure is listed, even though it's good, even if it was high, it would not put her at risk. And so the correct answer is your BMI of 42 kilograms per meter squared, because she is obese. Okay, so we have RK, who's a 68-year-old man who comes to the pharmacy to pick up a prescription. He wants to get an annual influenza shot. Which vaccine would you recommend to reduce cardiorespiratory disease? So this is just based on data. What do we have data on to reduce cardiorespiratory disease? So is it your standard dose vaccine? Is it your recombinant, your adjuvanted, or your high dose? And the correct answer for this is the high dose, because we found that in clinical trials, the high dose vaccine is more at, okay, I'll come back to the question, but so we high risk is, the high dose is the one that we found in that head-to-head study against Adjuvanted that showed that it does decrease cardiorespiratory disease. And high dose has been studied across all the realms to show that it's more effective. So for question 2, somebody said, wouldn't her smoking history also be a high risk indication? And absolutely it would. Smoking itself is not linked to it, but the fact that she's smoking, because remember on my list of complications, high risk, I didn't have smoking. But typically smoking is linked to lung disease, and lung disease would increase her risk. So if she has any kind of lung disease and she's a smoker, then it would increase her risk. Okay, so number 4, pharmacists are an integral to reducing misconceptions about vaccinations. Which strategy is most appropriate to convince a patient to get an influenza vaccine? So is it discussing the side effects with the patient, stressing the number of deaths that occur each year, using facts such as how many patients you vaccinated already, or referring the patient to a pro-vaccine website? So I'll give you a couple minutes to answer that. So this one's interesting. And so in this one, discussing adverse effects can especially help using statistics to help overcome patient concerns. So making sure that patients understand that there are some side effects, but the side effects may be low, like less than 0.001% of patients have this side effect that you're concerned about. I think stressing the number of deaths is not the ideal way, because scaring patients is not the best strategy that's proven to be effective. So instead, stressing the number of lives saved would be more beneficial. C is not going to be beneficial to patients, because most people don't care how many patients you vaccinated unless they're actually concerned about your technique and how you're going to administer them. And then finally, referring patients to a pro-vaccine website could be beneficial, but it's not the best scenario, because you want to have open dialogue with the patient. And then the last question on here is, which of the following is true regarding influenza virus? Is it people with flu are most contagious on the first day of symptoms? Is it healthy adults may be able to infect others beginning 3 to 4 days before symptoms develop? Young children and people with weakened immune systems might be able to infect others with flu viruses longer compared to healthy patients? Or D, symptoms typically come gradually over the course of a few days? And the correct answer for this is C. And so what we find is that patients are most contagious in the first 3 to 4 days after the illness begins. So B is not correct, because it's not before, but it's after. People are most contagious in the first 3 to 4 days after the illness begins. C is correct, and then symptoms typically come on quickly. So flu comes on suddenly, whereas this is where the COVID-19 diagnosis is a little bit different, because they don't say it happens suddenly overnight. It usually happens over a course of a couple of days. All right, so with this, do we have any questions? You can either unmute.
Yep, thank you. Thank you so much, Rupal. I'm going to go ahead and just leave that post-test up just as a reminder for any of our pharmacy attendees today. The pre and post-test completion is required for that ACPE credit. So we'll go ahead and just leave that poll active for any of you who are still have not answered right now. And we'll offer just another minute or so for last minute questions. So type them in the Q&A box now. And while we're waiting for those questions to be typed in, just a couple of reminders. Again, if you've requested continuing education credits for today's webinar, please make sure you complete the survey. This is this is applicable for nursing and CHW CEU seekers. That survey will pop up on your screen when the webinar is ended, and those CE certificates will be emailed out within the next week. And in addition to completing the pre and post test as part of today's live activity, we will also email pharmacist attendees the link and instructions for claiming the ACPE credit after today's presentation. And then again, if you'd like to view or share this webinar, the recording will be available on the Immunize Nevada website, along with information about future webinars. And that is going to be on immunizenevada.org/webinars, where that will be posted. And with that, we'll go ahead and go to the Q&A box. The first question that came in was, how would you strongly recommend someone to get the flu vaccine to make them comfortable with it if they're really concerned about an egg allergy?
Yeah, great question. And if somebody has an egg allergy and they know there's egg in a vaccine and they've never had it before, that can be concerning. So I guess patients that have egg allergies fall into two categories. If they've already had an egg allergy and they've ever had a previous vaccine, I would just tell them nothing happened then, nothing's going to happen now. But if they're really, really concerned, you can just order the recombinant vaccine on the outpatient side and be able to vaccinate them. So lucky for us, we now have an option where we have something completely eggless. And so if the patient at the end of the day, doesn't think that the data, because it's 1.31 anaphylaxis per million vaccinations, right? But if they're like, well, what if I'm that 1.31? Well, that's possible, right? And so we can always recommend the recombinant vaccine to patients. And so I would definitely go that route if you have somebody that's not getting vaccinated related to an egg allergy.
And that's Flublok and Flucivax,
Yep.
correct?
Correct.
Okay. Next question is, what do you say to people who say the flu vaccine isn't necessary this year because people are wearing masks and practicing social distancing?
Great question. And honestly, like this was me. This actually went through my head because I was like, well, I'm wearing a mask all the time and I'm not seeing anybody. I'm in my house, isolated. But the thing is that, and my kids are homeschooled. They're not normally homeschooled, but our schools are closed. So they're virtual right now. And so there's a really low chance of my family getting the flu. But we decided to kind of get vaccinated because schools can reopen at any time. There may be something that requires us, and we still have to leave to go to the grocery store, do something, right? And so just kind of discussing those pros versus cons with patients, why wouldn't you get the flu? What are the adverse reactions? Is there something you're concerned about specifically? For me, it's just that I fear needles and I was like, well, why get an extra needle if I don't need it? But I did end up getting it because I can't control everything. I have to go out to get groceries. And so there's always that small risk. But I do see a lot of people that have this concern. So definitely a great question. And I think at the end of the day, we just got to kind of point out that even if you're completely social distancing and wearing masks, you still have that risk that you're still going to be out in the community setting at one point or another, and you just don't want to get infected during that time.
Perfect. And then it looks like the last question that's come in is, if high dose is unavailable, which we're seeing a lot in our community, how do you strongly recommend just the typical flu vaccine to seniors, or what would you do in that case?
Great question. Yeah, where high dose is an issue, and it's geographically an issue in certain spots in the country. So if you can't get high dose, then you got to figure out, is there someone regionally or someone locally that can get high dose that you should refer the patient to? But if they're not, and especially now where we are, where we're October 27th, it's a little bit more concerning because, now we're going into the height of flu season. Usually flu season peaks in January, February, but by this time, patients should be vaccinated because we're going to start seeing the cases go up. And so at this point, it's almost beneficial for them to get the normal vaccine than no vaccine at all, right? And there's nothing that says that if they do find high dose and in the next month or so that they can't get it. But at this point, I wouldn't recommend that they get double vaccinated or they hold off on vaccination. So just kind of talking to them about, yeah, it's going to prevent 4 or 5 fewer cases out of 1,000, but it's not so strong. It's not such a high number that you want to not get vaccinated and get the flu instead.
Perfect. And I think you kind of answered this question with the question before this, but Lisa had posed a question in the chat saying that her facility is required that staff that had not been vaccinated against flu wear a mask. And she asked if now that everyone's required to wear masks in much of the country due to COVID, are you concerned about a decrease in people taking their flu shots? We kind of talked about that, I think,
Yeah.
mostly.
I think, yeah, the numbers are definitely going to go down in the number of people getting vaccinated that normally get it, because I've heard it from so many patients, and I told you it was a concern for me. But I will tell you that, like, there are a lot of facilities now that previously allowed patients to, or healthcare workers to not get vaccinated. Our facility has changed their stance. They say, you have to get your flu vaccine or you cannot work. Unless you have a legitimate contraindication, you have to get vaccinated. So this year, it's not an option that you can wear a mask and just work. And so I think it depends on your facility and what their requirements are. But obviously, because everyone's wearing a mask all the time, and the masks aren't 100% effective at preventing flu, right? And so in the type of mask you're wearing, unless everyone's wearing N95s, we don't know if it's going to completely protect you from the flu. And so at this point, I would just encourage patients to get vaccinated to the best of your ability. But I wish that I could predict what the number is going to be. I can't predict that, but I do think that the numbers are going to be less for influenza. I think it's going to be a milder season based on everybody wearing masks in the community and even in the schools.
Yeah, and I know in Nevada, we're seeing encouraging flu vaccination coverage levels in comparison to previous seasons as well. So let's hope that that trend is true for everywhere across the country.
Okay,
and with that, with that, we'll conclude today's NILE webinar. Again, thank you so much, Rupal, and to those of you who participated, and have a great day.
Thank you. Have a great day.